Thank you for being here. My name is Kirsten Auster. I am the director of the Medical Humanities program at Rice and also the Medical Humanities Research Institute at Rice. And I am absolutely thrilled to be welcoming you to this talk today by Dr. Melissa Creary. Before I have the pleasure of introducing her, I would like to pass the microphone over to my colleague, Dr. Keisha Ray, with whom we have organized this lecture so that she may also say a few words to you.
Hi, everyone. I just want to welcome you all for the McGovern Center. This is our fall speaker for our medical humanities scholarly concentration programs. And we try to make sure that we give our medical students as much medical humanities education as possible. And we know that this is a great addition to that. So thank you all students for being here. Thank you faculty, and we look forward to you speaking, Dr. Creary.
Thank you, Dr. Ray. And again, thank you all for being here. This is a really wonderful opportunity for all of us and all of you. I have had the great pleasure of hearing Dr. Creary give a talk before at a conference, and it was just really a true highlight and very inspiring. So I've been looking forward to finding an opportunity to bring her to speak at Rice since then. So thank you so much, Dr. Creary, for accepting our invitation. So let me just say a few words about our speaker today. Dr. Creary holds both a PhD and a master's in public health. She's an assistant professor in the Department of Health Management and Policy in the School of Public Health at University of Michigan. She's also senior advisor of public health policy and equity at the American Thrombosis and Hemostasis Network, and Associate Director of Anti-Racism for the Michigan Social Health Interventions to Eliminate Disparities program at Michigan Medicine. She earned her PhD in interdisciplinary studies, focusing on health, history, and culture at the Graduate Institute for the Liberal Arts, and a master's in public health at Emory University. Prior to joining University of Michigan, Dr. Creary spent over 9 years at the Centers for Disease Control and Prevention in the Division of Blood Disorders, where she helped create and lead the first national program and data collection system for sickle cell disease at the agency. Dr. Creary is an interdisciplinary social scientist who has worked with the sickle cell and bleeding disorder community as a scientist, policymaker, and public health researcher for over 20 years. And as you will hear in the talk today, her primary research interests include how science, culture, and policy intersect, particularly around ethical, legal, and social concerns. Her work is very much focused on health equity and using historical and ethnographic methods. And I think we're going to hear that in the presentation today. I want to say a word of thank you to one of our sponsors, which is the Rice University Bridge program. Bridge stands for Building Research on Inequality and Diversity to Grow Equity, and they have generously supported this lecture series. So we're very grateful to them for that. So Dr. Creary's talk today is called Justice, Its Bounds, and Making a Health Department Anti-Racist. Please join me in welcoming Dr. Creary.
Thank you so much for the gracious welcome and introduction. I really appreciate the time here with you all. I appreciate that it is after hours for you and you're spending it here. I am going to share my screen. I will be on the page a little bit reading my remarks, and we'll try to keep to time at about 45 minutes. If I could ask for a ping, a ding, a chat, or something, just to give me a 5-minute warning so that we can make sure that there's time for discussion, I would appreciate that. But I'm looking forward to engaging with you all and yeah, having a discussion about some of the things that I'll be talking about. So I will share my screen. Okay. So I too want to thank the sponsors of this talk and the series. I very much appreciate the invitation from Kirsten and Keisha, and appreciate the fact that there is support coming across Rice and the UT infrastructure to have these kinds of conversations. So today I'll be talking a little bit about a concept I developed called bounded justice, how it came to be, and how I am thinking about its applications, and more specifically, how I and collaborators are using it to help think about an anti-racist research project in which we are working with a county health department and its community members to help transform policies and programs. So our roadmap for today is I will take you a little bit through my positionality, which I'd like to start all of my talks with, and like to really kind of teach the value of owning one's positionality when one is conducting research or just being in a space when they're talking about research. We'll talk about bounded justice origin story, the contemporary case study, which is the application of bounded justice through this county health department project. And if we have time, a few slides on how we could think about applying a bounded justice methodology before we head into discussion. So I am an STS scholar at a School of Public Health and value the methodologies of ethnography and oral history. Before I became that scholar, I was constantly playing the role of insider and outsider, someone living with sickle cell disease, while also being a part of the public health apparatus at CDC that was creating policy at different levels for the sickle cell disease community. When I lived in Brazil for my dissertation, bounded justice was made crystal clear as I witnessed activists interact with governmental elites. As a professor invested in health equity and anti-racist teaching and research, I wanted to question everything, including disciplinary norms and assumptions, even if that means pushing back on the processes of health equity, which is where bounded justice kind of stems from. And you'll see here a lot of the things that Kirsten already discussed in terms of my own trajectory. And a lot of that trajectory that I think makes sense for who this audience is around interdisciplinarity and the ways that we can use the humanities to help think about how we deliver care or think about population health or individualized health and illness. And so part of that training for me happened at Emory University as part of the ILA program, which is at the time was one of the oldest interdisciplinary programs in the United States. It has since been shuttered at Emory. But at the time, I was getting really rich training in history of medicine, Brazilian studies, anthropology, sociology, and genomic science, because in that interdisciplinarity, it was kind of choose your own adventure and how I wanted to, set a course for what I wanted to study and who I thought I wanted to be at the time in grad school. And so those things kind of convalesced for me, such that I consider myself now a science and technology studies scholar, again, housed in a School of Public Health. So I have a master's in public health. I worked for years at the CDC. So I'm very much invested in public health. But I'm interested in uprooting it at times, making sure that we're not ahistorical, making sure that we're asking important questions. And also the ways that I think about my scholarship today, I also think of myself as a bioethical scholar as well. I certainly see bounded justice lending itself to bioethical conversations. The scholarship, as I see it, are primarily in three buckets: public health prioritization of sickle cell, anti-racism and public health transformation, and then equity, belonging, and justice. And that is kind of how my work plays itself out in across these themes. So it's important that we start out with knowing what sickle cell is, but also why I think it's important. Most of my work uses sickle cell disease as a lens to tell a broader story about policy development and attempts to achieve equity. Studying the mechanisms of Brazil's policy development and the contemporary implications for those living with sickle cell disease not only provides us with a case study of bounded justice as a concept and conceptual framework, but also sheds new light on the phenomenon of policy development itself. So we'll talk a little bit about the origins of the concept. And the origins come from when I was studying in Brazil, this policy called the National Policy for Black Population Health. In 2006, this policy was approved by the National Health Council in Brazil to bring attention to a package of diseases thought to disproportionately affect Afro-Brazilians. It was the first piece of legislation from the Ministry of Health that officially recognized Black Brazilians as a vulnerable population, warranting separate consideration. This is remarkable because embedded in this recognition of vulnerability is the promotion of a biologically and culturally distinct Black population in a nation known for its racial ambiguity and fluidity. And so you'll see here that it was formalized in 2009. It took 3 years from being created to get formalized, and the ways in which it kind of conceives of Black population health. Sickle cell disease really was one of the primary illnesses, diseases, health concerns, because it was something that was attached very easily to Blackness. But you'll also see these kind of broader health topics as well: infant and maternal mortality, sexual transmitted infections, and then we see social determinants of health showing up with violent deaths and mental health issues. So this was done, this idea of promotion of a policy for a vulnerable population, this was done through policy development processes that were embedded in the Brazilian Constitution of 1988. The accompanying and newly reformed healthcare system was predicated on the need for increased community participation in the political processes of health policy. It prioritized the social rights of its citizens and called for co-management of municipal, state, and federal government. Yet, despite this mandate for citizen participation, the justice-based health policy, as described, is unable to address the underlying mechanisms that generated initial inequalities. The constitutional mandate was based in principles of equity, and it takes this kind of intentionality to move towards equality. This mandate has increased the role that citizens and organized civil societies play in the development of policy. And these political structures at the time were groundbreaking innovations in the Brazilian government because they enabled a greater number and variety of stakeholders to take part in the decision-making process and defined areas of institutional responsibility more clearly than before, guaranteeing that each level of government supports national health policy implementation. And so what you see here is kind of a complicated schema of how the Brazilian health system was configured and is still configured, and in the ways in which social participation is embedded at 3 different levels: federal, state, and municipal. So there was a constitutional mandate for inclusion in policy, but I argue a lack of recognition for the ways in which the bodies invited to the proverbial table historically embodied social exclusion, what brought them to the table to begin with. In essence, these attempts at equity, even while operating in a health system that is based on universal health care, they are bounded by larger societal, systemic, and structural factors. Bounded justice challenges the idea that health equity is an achievable goal, given that all other factors will never be equal. So just to make sure that we are on the same page in terms of a shared understanding, this is the way that I'm thinking about equity. It means social justice or fairness, an ethical concept grounded in principles of distributive justice. And for purposes of health, distributive justice denotes a just distribution of resources according to the needs of the population. So we often conceptualize equity in the vertical framing. The more a particular population needs something, the more we adjust our distribution of those resources to fulfill that need. So keep this notion of equity in mind as we move through the presentation. It is the limits of equity, even when intentionally built in and even when codified, that help describe bounded justice. This QR code will take you to a visual abstract if you're so inclined. Programs, policies, and technologies, particularly those concerned with health equity, are often designed with justice envisioned as the end goal. But rarely do we think about the ways that generations of disadvantage, may have made the delivery system for justice ineffective. Bounded justice suggests that it is impossible to attend to fairness, entitlement, and equity when the basic social and physical infrastructures underlying them have been eroded by racism and other historically entrenched isms. And so what I'll lay out here briefly for us today is an exploration of bounded justice as a concept, and how we might think about methodology and praxis as we move through. And this is a schema that I like to think about to help me kind of further conceptualize how bounded justice is operating. And essentially, it suggests that when policies, technologies, and programs are being created, are being designed, are being implemented, that we are hitting the tip of the iceberg, even when we have the best intentions and we are being intentional towards addressing equity. And that, in fact, there's deep, deep equity that is needed. We have to excavate a lot deeper than we think we do. And very often we're creating these texts, policies, and interventions without the keen, deep, long-term insight of communities that will help us further understand exactly what's underneath, and how long it's been going on, these things underneath. And so bounded justice is calling for a much deeper excavation to address the deep equity that's often needed to address those in historically marginalized and minoritized populations. So in this portion of the presentation, I'll go over how bounded justice came to be in a historical context. Sanitaristas, or physicians who were part of a movement to address equity in Brazil, were embedded in the government and helped with the creation of the universal healthcare system in 1988. The National Black Policy, operationalized in 2009, was guided by the mission of a racialized health movement and drafted by individuals who demanded action from the state, given the failures of equity production that the new constitution promised. Despite this mandate for citizen participation as a way to build equity, the justice-based health policy was unable to address the underlying and deeper social inequalities embedded in individuals and communities, specifically those disadvantaged by racism, because attempts at health justice and reparation were bounded, again, by these larger societal, systemic, and structural factors that were not recognized as part of the policy and system building. If we turn our attention to the timeline in the slide, it starts in 1964 to help provide context, but way off the timeline is a long history of colonization, slavery, and oppression. The 2009 policy is an attempt to address all of these things. The text of the policy for the Black population health begins with guiding principles. And it says, this policy is grounded in constitutional principles of citizenship and human dignity, the rejection of racism and equality. With these principles are the joining of popular participation and social control, key tools for the formulation, implementation, evaluation, and possible redirection of public health policies. And so this idea of community participation really was important as folks were developing how the processes would work towards the creation of the rewritten 1988 Constitution and these health policies embedded within it to create a new public health system. So this policy, drafted in 2006, reminds us of the commitment that was made in 1988, where this Constitution was supposed to address these items: citizenship, of human dignity, rejection of racism, and equality. So this slide depicts an image from the 8th National Health Conference in 1986, which urged for health reform and development of a new public health system based on universality, completeness, and equity. And then fast forward to 2009 and beyond, where these tenets have been translated into the policy for Black population health. And during fieldwork, I saw the slogan throughout my fieldwork as handouts, stickers, and covers of books. The new healthcare system was predicated on the need for increased community participation in the political processes of health policy. It prioritized the social rights of its citizens and called for co-management of municipal, state, and federal government. This is what they refer to as contrôle social or social control. The terminology may seem counterintuitive, this idea of social control, as one may assume that it's the government who's attempting to control the political processes for health. But in fact, it mandates that members of the community are directly involved with the creation, implementation, and evaluation of public policies. The social control model came out of the work of two groups: socially mobilized citizens who were distrustful of an authoritarian and inaccessible regime, and a group of more elite health reformers bent on addressing Brazil's inequities. So many of you are probably familiar with this graphic meant to illustrate the difference between equality and equity, where three individuals of varying heights stand in front of a fence on either same-size crates, which means that only the tallest of the three can see over the fence, depicting equality. And on the equity side are stacked crates so that they can look over the fence at the same height. We, the interpreter, are to liken the crates to some type of resource: money, personnel, better access, better opportunity, policy. And the more we are to assume, the more resources. As a visual reminder of this distribution of resources, the individual is elevated by standing on the increasing crates. This is a representation of vertical equity, an attempt to achieve an equal outcome in which people are treated differently according to their initial endowments, resources, privileges, or rights. There have been several critiques and adjustments to that image I just showed you, with some saying that it really does not depict reality, that this, in fact, might be a better visual. The concept of bounded justice critiques the vertical processes of distributing justice and equity and suggests that they do not go deep enough. Distributive justice is a tiered process that assumes that the intended recipient is able to adequately and efficiently accept and properly retain the benefits of justice. Equity in health is an ethical value, normative in theory, but often fails to structure practice. It is an ideal and a policy goal, but the justice that practitioners seek is often imagined unrealistically. When programs are narrowly constructed to benefit marginalized populations without redressing the cumulative effects of disadvantage, the results constitute a bounded justice. But let's think about crates in this scenario. What can crates do when you are incarcerated, when you're stuck in a place that the crate won't fit or matter? How effective are interventions and policies aimed at addressing equity when the intended recipients have embodied generations of racism, deprivation, capitalism, genocide, and social exclusion? Portrayed are three people of equal stature, experiencing external forces that distort how tall they appear. This image reveals biased foundational beliefs about innate differences in value or merit that often undermine the success of equity-based interventions. Bounded justice is created in concert with both well-established and novel schemas like structural violence, ecological frameworks of health, intersectionality, embodiment, and social exclusion. Each of these offer distinct ways to help conceptualize how deployed justice tactics fall short, while also working together to help explain larger societal phenomena and the ways that health happens. Each further contribute to the ways we value or don't value lived experience in the explanation of health outcomes, policy development, and interventional design. Even if we were intentional and well-intentioned about addressing social justice in health, the depth of intersecting oppressions that have been embodied since before one was born is bound to undermine the impact. Understanding how personal, situational, and sociocultural factors such as racism, sexism, classism, and homophobia intersect has far-reaching implications for policy development, knowledge production, and the design of interventions. And here is Nancy Krieger's model in which she kind of depicts how racism is happening across the life course at different levels and have different intersections. So what does that mean when you're trying to do the right thing and make sure you're inclusive? Is this the time when we are now, in this time when we are now turning to work groups and task forces, how do we position people to have power once they are around the table? We often think about inclusion in a vacuum and not as a fraction of the whole picture. We cannot then think about inclusion without interrogating exclusion. Social exclusion defines social disadvantage as an outcome of social processes instead of assigning it as characteristics of any one group. Social exclusion is a product of people's relationships with the labor market, consumption, institutions, social relationships, culture, and geographical space. In public health, we recognize this as an ecological framework to health and the basis of epigenetics. If we are prompted and called to design more pathways of inclusion due to the indignities of society and as a form of justice, we are also forced to reckon with the ways in which embodied exclusion will affect the efficaciousness of these designs. So here is a screenshot of a part of an article that came out in 2020, as many articles did, discussing racism in the space of the pandemic within a pandemic. And I just wanted to turn here the ways in which many times in the checklist that we received, it was to include patients of X, Y, and Z or their advocates on an anti-racism task force. And so Bounded Justice really wants us to conceptualize the kind of seat that they are being forced to sit in and the ways in which we are actually being welcoming when we invite folks to come to these tables. So I think bounded justice has wide relevance as a praxis to help quantify justice, contribute to research and conceptual ethics, to serve as a lens from which to evaluate policies, and as a biopolitical lever to raise awareness of unforeseen consequences of our current policies and practices. And while I believe there is research to be done to help develop an evaluative tool that can assess how equitable or inclusive certain policies and interventions are being enacted, there is space for us to be mindful how the vertical processes, of the vertical processes of distributing justice. There's also call for a new language for the word interventions designed for justice in public health. An intervention is usually time limited and seeks to change a specific behavior or habit. And due to the deep-rooted societal forces that bounded justice wants us to contend with, those of us invested in the work of unbinding justice must reframe our approach. What I'm suggesting is that there is a relational positioning between vertical equity or justice distribution and how deeply we must dig to unearth the real needs of a community. We cannot attend to policies specific to sickle cell disease or COVID-19 as an example without first recognizing the ways that deprivation and social exclusion are embodied as a result of colonialism and slavery unto bodies who are also contending with a medical diagnosis. That is not to say that in the moment that we do not in parallel address the urgency of the acute ailment for populations so obviously in need, but that we are attentive to both the acute and the chronic, the longer, deeper interventions that true equity calls for, while also applying the Band-Aid to address the thing that we're trying to deal with immediately. The challenge of what the concept calls for, equal attention to the deep socio-historical injustices in parallel to the quicker fixes that a moment may call for, is daunting and overwhelming. How do we address colonialism as the root of inequity? How do we adequately frame and fight for health equity as a human right? Even if equity is unattainable in its completeness, as bounded justice suggests, it is our role as policymakers, practitioners, interventionists, technologists, providers to design programs, policies, interventions, and technology with this limitation in mind, and then redesign as necessary. If praxis means moving back and forth in a critical way between reflecting and acting on the world, and we are compelled to create a more just world, we must theorize, study, evaluate, redesign, reevaluate, act, and then return to the cycle, with reflection embedded throughout, to determine the most effective ways to distribute justice. And what this looks like is stamina. Bounded justice also seeks to help us understand the kinds of stamina needed to do this kind of work, because the actions around the excavation of deep equity means that it's going to take a long time, it's going to invest a lot of investment, and it's going to be exhausting. And so when we understand that, and we understand that justice is not something that ever necessarily gets attained, but that we're always moving towards justice, that is an imperative instead of the end goal, then we understand how we must build stamina as a research team, as a collective, as a community, as collaborators. And so I'm going to switch now to think about applications of bounded justice. I have this theory, and now I'm trying to think about how to build an empirical corpus around this. And so there are several projects and papers that are addressing this. And for the sake of time, we're going to talk about the Antiracist County Towards Justice Project. And if we have time, a Bounded Equity for Cannabis Legislation project, which has led me and a team to think about what bounded justice methods might look like. So during the height of the pandemic, we had to contend with, as a nation, what we began calling a pandemic within a pandemic. And this was the societal and public health and scientific hyper recognition of racism and the official call that racism indeed is a public health issue. And so with that in mind, I'm sure across Rice and UT in different kinds of ways, attention was kind of brought up for how we can address these issues. In Michigan, there was new availability for pots of money specifically to address and tackle issues to move us towards being more anti-racist. And I received one of those grant funding opportunities, was awarded one to talk about and discover, excavate, think through a pilot project for developing an anti-racist public health department. And so we were really interested in the opportunities and constraints for local health departments to transform into anti-racist institutions that can disrupt structural racism and resulting health inequities. And to do this, we were partnering with the Washtenaw County Health Department to identify key opportunities and limits. And limits is the bounded piece, these limits on anti-racist institutional transformation. So here's a conceptual framework that helped to kind of guide us, in which we were thinking through the ways that there are these embedded structural systems all throughout society. Sorry, moving things around. Embedded structural racism in a number of systems throughout society. And these systems lead to racial health inequities. But if we in the local health department were to attend to people, policies, programs, and power sharing in intentional ways and help transform who's represented, the policies that are brought forth, how power is shared in terms of local governance, and the ways in which programs are developed, and all of those things that are happening within a local health department, especially when we consider the amount of services that are delivered through a local health department, that all of this can disrupt this, the mechanisms between the criminal, financial, political, health, and educational systems as we consider social determinants of health, disrupt its pathway in the creation of these racial health inequities. And so we're thinking about bounded justice here as a racial equity diagnostic. And we're thinking about this through racial equity transformation, thinking that it's intersectional and interconnected, that in fact, as part of this project, we are trying to help local health departments understand that they have to go beyond their assumed scope to just deal with the specificity of health and to expand it outward. We're also thinking about bounded justice to help us understand that, again, when it comes to the stamina piece, that real equity work is beyond quick or easy solutions and requires a long-term and ongoing commitment rooted in individual and institutional level stamina. So this is a co-created collaboration between scholars at the School of Public Health at University of Michigan, Washington County community members, and the Washington County Health Department. And this really is a joint project, and it's interesting because at the top of this project, when we came into the community, because of the ways in which research is known to be extractive, and the ways in which communities are often distrustful of large institutions, academic institutions like University of Michigan, there was a lot of conversation around the need to do more than just provide input. That in fact, that this would be a co-designed process. And as much as we said this, there was a lot of skepticism. And one of the things that came up consistently was this argument about how the community members refused to be a part of yet another process that took from them without giving back. And there was rightfully so an assumption and a lot of work on our part to keep coming back and to be consistent, to let everyone know that essentially this was something that wasn't happening unless they were at the table. And then we had to work to make sure, as I talked about earlier, that this table was as welcoming as possible. And indeed, that did take a lot of time, such that by the end of the process, there was a lot of transparency built into this project. Washtenaw County health staff and community members and researchers were able to be transparent and really clear about the needs, the barriers, the wants of the community when it came to trying to attempt to be anti-racist. So the project goals included the cultivation of a collaborative relationship with the Washington County Health Department in order to support anti-racist practice and change in local public health delivery. We wanted to identify a baseline for knowledge, attitudes, and practices around anti-racism. We wanted to increase capacity for anti-racist engagement in internal processes and external programming, and collaboratively develop a racial justice impact assessment, which we called the RGIA, to assess the county health department programs with respect to anti-racist principles and practices. And we currently just got a second round of funding in which we are going to be pilot testing this tool. This tool is modeled after other health impact assessments, has been co-created as part of this project, and is helping to guide the county health department towards the creation of anti-racist policies and practices. We're actually trying to actually put it into practice so that we can see how it works in real time in real life. And so we talked with a lot of folks across the staff in the health department, from folks in finance, from folks to environmental health, where we heard a lot of things about, I have to worry about being called to address bats in someone's roof. How does a racial justice impact assessment affect me and my work? To folks who were, more on the ground and involved with the community. You can see by this slide when we talked to them that a lot of employees expressed fatigue. A lot of employees expressed skepticism. Leadership team was more focused on internal dynamics and structure. The staff were more optimistic than leadership, who had been there for a longer time, about progress towards being anti-racist. And so there were all these kinds of honest problematics that came up when we tried to kind of assess how people conceptualized their own space, their own health department becoming anti-racist. When we talked to the community equally had frustrations. They were, as I said, very transparent about the ways in which many other projects came in and were extractive. We ourselves as researchers had failed focus group aspirations where we wanted to talk with the community about their experiences, and they said, we've talked enough. There are so many people we've talked to and nothing has happened. And it made us take pause to regroup And they said, go read the things that we've already helped produce. Go do your own homework. And that was something that we took heed and that we did. And then we came back to them and we had to kind of redesign. So one of the other things that was clear was that there was a lack of understanding between perceptions of community input versus co-creation, which I talked about a little bit earlier. They did not want community input, and it was hard for us to explain to them that we too wanted co-creation and we had to prove it to them. And in general, there was a lack of trust, again, understandably so, and confidence in partnering with the health department, given historical feelings around community engagement. So the racial justice impact assessment was collaboratively designed tool with significant input from staff and the Washington County community members. It's a tool designed to help the health department better identify areas of concern and thus appropriate and impactful interventions. As said earlier, with the conceptual framework in which we were thinking about these 4 Ps for anti-racist practice, there are preconceptions, people, power sharing, and policies. And so we really had to go through this process where all of us in the group had to decide how to define preconceptions, people, power sharing, and policies, and choose these Ps as the ways in which we were going to think about the tool being implemented. So the process for getting to that tool involved 6 session series over a year and a half. It was responsive and adaptive. And in terms of the session planning, there was power sharing with participants in the norm setting and session planning. There were structured opportunities for engagement with health department leadership and multiple opportunities to refine and rethink in the co-creation process. So this entire space was an iterative one in which if something, we were being reactive to the pauses that need to take place, to the hardships that would occur as humans were humaning. And really, it was the space where people got to take honest, or give an honest kind of outlook about the realities of turning their health department and what ownership of their department, what that meant, and again, what it kind of meant for people to kind of reconceptualize the health department as anti-racist. I'm just going to check the chat, make sure I'm not missing anything. Okay, I'm not. So we, when we're thinking about the 4 Ps, preconceptions, people, power sharing, and policies, the point is that we want to use these 4 Ps to move the health department across the spectrum. And so the spectrum is being adapted by this spectrum above at the top of the screen of it's a continuum for making a multicultural anti-racist organization. And we took this model and have applied it to what that might look like for a health department to work along their own continuum towards becoming more anti-racist. And I want to point you to that final column all the way to my right, so maybe your right too. This fully inclusive anti-racist multicultural organization in a transformed society, a fully anti-racist public health department in a transformed society. So this is where bounded justice comes in, because there needs to be an acceptance of the reality that we will not ever live in a fully transformed society, right? So the fact of the matter is that we're never going to actually achieve number 6. But the point is to keep moving across the spectrum to be as close to number 6 as possible. And that is the space of where stamina is needed, and this idea that we're always moving towards justice, that justice is an imperative, it's not an end goal. So some of the lessons learned that were super crucial when we were helping to co-create this process and tool is that process is as important as the desired end product. We were really happy to say to our grant funders that we have this report, we have this tool, but really the thing that we learned the most from and that we're hoping to replicate, although we never will exactly, is the process that took place, the kind of muddy spots in the middle where we really were able to dig deep about what the community needs. And in that digging deep, created a space for safe communication so that those things could be elevated and then translated in particular ways to move us towards the development of the tool. So there were opportunities for shared learning. We built group capacity, rapport, and trust through this process. There was power sharing and collaborative processes, and these things take time and require flexibility, a key lesson learned, but also kind of a duh. And then that the health department, that commitment, follow through, and accountability really were key for folks to find trust in the process about what's next, to understand that this wasn't going to be another failed project that sat on a shelf someplace, but that we were actually going to move forward towards producing, hopefully, policies and partnerships and programs that were going to benefit the actual community. And so all of this got wrapped up in a report that I'm happy to share with folks if they're interested, and then I can talk about a little bit more. I'm going to check the time. It's 6:46. I think I'm going to pause here, but take any kind of Q&A about ideas of methodology really quickly. This methodology comes from the space of which we're trying to think about cannabis equity policies, and this tension between cannabis being a prohibited object and also a legal commodity that can drive the production of new economic markets and wealth. As you know, the legalization of cannabis is kind of catching across the US. And as we're thinking about this, we're thinking about how more scholars are going to want to be interested in doing cannabis research. And so we kind of drew out a path for empirical research for those scholars with bounded justice in mind. And really, this is about using methodologies that allow for examining the historical and social depth of the issue, using qualitative methods like ethnography, oral history, community-based participatory research methods, making sure that the historicization is happening of race and place. Some of the ways that we're thinking about this is conducting a hyper-localized, I think bounded justice and the methods therein are about getting hyper-local beyond zip code down to neighborhood. How is the thing you're studying impacting community on a deeper, more local level? You might come to a fuller understanding of that through analyzing voting patterns, funding decisions, infrastructural investment and disinvestment patterns, sustainability of past public health interventions. You might review news articles and books about the locale. You would definitely go through city council minutes to see the things that were brought up, the things that were ignored or shut down, trends in city socio-demographics, and publish scholarly articles to support all of that. And so I went through that very quickly, but I'm happy to talk about that more in Q&A, and thank you for your time.
Thank you so much. We really appreciate that. That was excellent. Thank you. Thank you so much. So we have a little bit of time. We have about 12 minutes to open it up for Q&A. I wanted to give students first dibs, but so students, while you're thinking of questions to put in the Q&A, let me go ahead and start with Dr. Mary Horton has a question. Someone I think you know. How much has this model been communicated, and are there departments of public health interested in following this programming? She asked.
So how much has this model been communicated? Say, I know you can't. We're not in that kind of Zoom. Okay, let me try and interpret. How much has this model been communicated? Are you saying how much has this model been communicated in terms of scaling up? So other kinds of other community, other public health communities, other departments? Yes. Okay. Thank you, Mary. So yes, that I think that's part of what's next for us. We have been having meetings with Centers for Disease Control and Prevention, and plan on reaching out to folks who the organizations for the national, county, and local health departments to have these conversations. We presented our work to the national network of folks who were funded, the local health departments, county and state, that were funded for the latest release that's now ending of COVID funding, to talk about this model, as well as talking to CDC leadership about this model, with efforts and ideas of how do we kind of move this forward and kind of scale up. So it's a plan to kind of have greater conversation with more public health departments. It started when, there was about 110 representatives across the US that got a slice of this presentation. But in terms of, a more formal way of implementing this on a national scale, that is one of the kind of long-term plans for this project and the researchers within it. But we're still in, the baby kind of embryonic stages of developing. The tool has been developed, but now to kind of pilot test it, and then to think about it on a regional level and then national level. There was a lot of interest from the CDC standpoint, and we're in current conversations about what that might look like in the future.
Great, thank you. I guess I'll use this time to ask a question. So our students are medical humanities scholarly concentration students, but they are medical students primarily. So thinking about what you were talking about with positionality, and then just your experiences in the profession, be able to use your expertise or in your knowledge about positionality. How would you give some sort of advice to medical students and how that can enrich their current status where they're students, but also going on to be physicians? Many of our students are fourth years and going on to residency next year. And what if you have any advice for them based on your experiences with positionality?
Thank you for that question. I think the positionality is really important because it's around a situational relatedness with the world. And it's a part of having kind of a deep honesty and reflexivity within oneself over time. So an understanding that one's positionality is based off of social identity and where you are, and how you could apply that specifically to the practice of practicing, or how you think about that when you decide to engage with certain patient populations. If you want to become an academician, what that looks like when you're thinking about the research questions that you want to answer, who you decide to be a part of your team, your research team, how and if you engage with community. I think it's so important to be able to understand your positionality, to own it, and then to be transparent about it so that other people have permission to then not only see who you are and what you stand for when you talk about your positionality, but for you to be a model for others to kind of understand the power of what positionality can do, the owning of that and the transparency of it. So, I want a physician that understands and is willing to accept when I come in to say that, hey, I am first generation, immigrant daughter who has sickle cell disease. And yes, I have a PhD, but also these other things are happening. And this is the way I've interacted in the healthcare care system. And I have found that when I kind of express my whole self to my physicians, that it gives them permission to accept, but then also to let me know where they are as well. And that absolutely builds trust in a really meaningful way. And when I'm able to understand where you're coming from, I'm able to relate differently, and I'm able to understand, again, like how you're going to, in my mind, fight for me, how you're going to make sure that I'm really well cared for. And I'll be able to tell, about whether or not I think you deserve my trust, um, with how open you might be with your own positionality.
Thank you. Let's see. Well, wait for other people to have questions. Kirsten, did you have a question or a comment?
Oh, yes, I do. Thank you so much for that incredible talk. It was really fantastic, and you brought so many pieces into the conversation. One that I wanted to ask about was making the table truly welcoming, as you described it, for the community members. I thought that was a really powerful way of describing a key part of the work that you were doing, and understanding where the community members were coming from and why the first setting of the table may not have been welcoming enough in some sense. Can you talk a little bit more about what that process was like of making the table more welcoming?
Specifically for the public health project.
Yes.
Yes, I will. So you're right in that when we, the researchers, first introduced ourselves to the community, I'm not even sure that there was a table to have them sit at, honestly. And I think that it was tense because they had a monthly meeting, and we were going to take up maybe 15-20 minutes of that meeting. We were going to kind of introduce the project, and admittedly, this is not a community-based participatory research project in which the community was invested from the very beginning. The community didn't help us develop the research questions. Really, this happened because of all of the chaos of the pandemic and this bolus of money that happened, and the way that power structures work, right? Where someone in the Washington County Health Department reached out to one of my research partners and said, hey, there's this opportunity here. And then everyone scrambled quickly, and now there's a project and there's no real inclusion of community, right? So to be fair, we entered that space where we're like, hey, this is something that we got funded for that we really want to do, and we really want to include you. So of course, I think they were like, here they go again. Here are some more folks coming through with a project that they're going to try and force on us. So I think the immediate interaction was a little tense. I think the immediate interaction was too short. And it took us coming back several times. People then said, okay, I'm interested. Then we began to meet with people on one-on-one. We began to go to, restaurants to have dinner. We went to, community health events or community events in general. We just started showing up so that the community could see our faces, and the community could kind of see consistency with who we were, and that we truly were trying to make this be a different kind of project. Then once folks decided that they were going to sign up for the actual kind of research collaborative group, we began to meet, for 2 hours at a time. We fed them. Food does an immense job of creating community. We had music, we laughed, we talked, we discussed really real things that were happening in the community, the ways in which we gave folks space for the community members to be transparent about how they felt during COVID, how they felt exploited, how they thought things were very racist. Like we just gave them a lot of safe space to have these conversations, and everyone respectfully listened and owned it, even despite their frustrations, from the Washington County Health Department side, right? Because they too are exhausted. They too are, tired of being labeled in particular kinds of ways. They too are fatigued on different levels. And we had to address that as well. So I think it was really about a kind of sustained, transparent, real, but safe space that we were able to create.
Great, thank you. We are about at time. And I want to be respectful of your time. We are very appreciative that you took time out to speak with us. Thank you so much, Dr. Curie. This was great, very enriching for ourselves and for our students, and I know that they appreciate it. So everyone, if you could thank our speaker, and once again, we appreciate you, and everyone have a very good evening, and I will turn it over to Kirsten.
Thank you, Dr. Ray, and thank you again, Dr. Creary, for this fantastic talk. It's been really wonderful hearing your research and the work that you're doing. I want to just let everybody know that we have another lecture in this series that will be coming up on October 26th. Dr. Kim Gallen will be giving a talk and a link, you know, Dr. Gallen, and there's a link that was just posted in the chat where you can get details about the event and also register for it. It will also take place on Zoom, so you can join in from anywhere. And with that, please join me in clapping, snapping, wherever you are for Dr. Creary. Thank you again so much. And that will conclude our event for this evening. Thank you.